Is it like a webinar so people can't speak, right?
Yeah, they can ask questions and
On
we
the chat?
can, yeah.
Or okay, got it. Can they actually unmute their mics or just chat only?
I think it's chat only for the meantime, but I can allow them to talk.
It's okay. Chat is fine too. I'll try to look at. I'll have the chat open on the side then. Sounds good. Let me put the chat over here then. And I'm not sure if I'll take the whole hour, but I'll try. But if it ends a little early, just FYI, it might happen. Yeah.
Oh, that would be good. That's awesome.
Yeah. That way people can just have a break because I just have these topics. So.
Thank you. All right, Dr. Kim, let me introduce you first. So Dr. Kim is actually a trauma and acute care surgeon at Harvard Hospital. He had a MD and MBA background from Harvard University, and he continued his general surgery training at New York Columbia University Medical Center. Now, Dr. Kim has industrial experience in medical device, early prototyping, and trials and product development. So I think it's interesting, and I'm excited to have Dr. Kim here with us to give us an review about critical care ABSITE review. Dr. Kim, you please.
Thank you. Thanks for the kind introduction, and hello everyone. Nice to meet all of you. I know you got a long day ahead, so I'm really grateful to be on the early part of this day. But I wanted to make this as high yield as possible for you guys for the ABSITE and the written and oral boards. Critical care is all, as you know, it's a big part of the written board and almost always on the oral boards, at least as one scenario, because it's a huge part of what we do. So haven't taken the ABSITE 7 times. I did 2 extra during research. I tried to make this as high yield for you guys as possible. All right. And just a quick disclosure, I am a medical device consultant for the Primetime Medical, which is the Roboa device company, and Centes, which made a new self-clearing chest tube company. So, but neither of these will be mentioned or relevant to this talk. So overview, so we're gonna try to go over the shock types and physiology first, go over sepsis and septic shock, respiratory failure, vents and ARDS management, pulmonary embolism, acute liver failure, abdominal compartment syndrome, brain death testing, and then sort of end with miscellaneous stuff that honestly I would just cram the week before your test, because some of the stuff is just test taking, but I think all the other topics are highly relevant for your clinical practice as well. All right, we'll get right into it. So shock type. So as you know, there's hypovolemic and hemorrhagic shock. That's the most common shock that we see in our post-op or trauma populations, but there's also cardiogenic shock, septic shock, neurogenic shock, and technically obstructive shock as well. I put on the columns here, so cardiac output, central venous pressure, and systemic vascular resistance. There's almost always a question on this to sort of see how you understand how the shocks work, so I'll just quickly go over it with it. So in hypovolemic shock, as you know, the tank is just empty. So the preload is low, so cardiac output will be low. The tank is empty, so CVP has to be low, right? And in response, your body tries to stay alive by squeezing down on your arterioles, so your systemic vascular resistance will be high. In cardiogenic shock, by contrast, the pump fails, right? So the pump is not working, so cardiac output is low. That's the primary source of what happens. Since the pump is not working, everything backs up, so your central venous pressure should rise very highly. And then in response, as your pump fails and you get hypotensive, your systemic vascular resistance goes up as well. Hope that makes sense. And if you have any questions, just put them in the chat. I'll try to address them as I go or at the end, depending how things look, okay? Then septic shock, the main issue with septic shock is what? It's vasodilation from an altered host response to infection, right? So septic shock, the systemic vascular resistance goes down and you get high because of that. And interestingly enough, your body, I think of this as like your body's trying to fight the infection, so it goes into high-speed rev mode. So initially your cardiac output goes really high up. Obviously, in the late stages of septic shock, then your cardiac output can drop because you're no longer able to keep up and perfuse your body. But in the beginning, and the CVP will be sort of sideways, not really change, because it's really a systemic vascular response issue, a resistance issue that causes everything. And then lastly, neurogenic shock. So I know most of you know, but neurogenic shock we see often from spinal cord injuries or trauma in the C-spine and high T-spine. That really is a issue now with your sympathetic nervous system able to squeeze down and add vascular tone. So again, your systemic vascular resistance will go down. And in response, I think of it, all the blood is just pulling in the tissues and all the fluid is pulling tissues. So your CVP drops. And as your preload drops, your cardiac output drops as well. So just wanted to make sure you guys understood all this because they're all slightly different and they like to test this subject a lot. So whether you understand it or not. And I think the best way to understand it is what is the primary source of what's causing the problem and then seeing what happens as a result. So the only thing that's not intuitive is that cardiac output goes up with septic shock. So that's something just to keep in mind. All right, so for sepsis and septic shock, as you all know, 2021 surviving sepsis guidelines came out. My program director in my critical care fellowship actually was one of the writers for surviving sepsis. So I had a good 3-hour lecture on this subject, but I'll boil it down to one slide for you so that you can understand just the takeaway points. So the most important thing to get away from sepsis treatment is that you got to give antibiotics as soon as possible, ideally within 1 hour. And they say if you can get blood cultures or cultures beforehand, that's great, but never delay antibiotics because you're trying to get cultures for hours and hours. And they've actually done good studies showing that mortality goes up every single hour of delay of diagnosis and antibiotics given. So just if you can take away one thing from sepsis and septic shock is that you got to give the antibiotics and broad spectrum antibiotics really early as soon as possible. Lastly, secondly, fluid resuscitation. There's been, they did studies on restrictive versus liberal fluid resuscitation and found no big differences. So for test taking purposes, you just say 30 mg per kg bolus, I would give that. And then, check a lactate. Vasopresses early to maintain MAP greater than 65. So now really the categorical first line of choice is norepi and vaso as second line. We used to use like dopamine and epi as first, all those things, but now norepi is the first line. So that's sometimes a test question as well. And then lastly, you got to measure lactate and trended. And the other stuff that you guys all know, make sure you get source control if it's dead bowel, antibiotic stewardship as you narrow your antibiotics with cultures, and continue supportive care. And be judicious with your fluids. For the Q-SOFA score, I think that's relatively new since 2021. So it's really only 3 items, but sometimes they like to ask you about it as a multiple choice. So I think of these as the things that we think about when we go to examine a new patient as a consult. So when you see someone as in the ER and the ICU, what makes them look sick? It's that they have altered mental status, right? That they're tachypnic and they're hypotensive. So just think of those 3 things as probably the things that you catch when you're examining someone. So those are actually in your Q-SOFA score as well. And this really just helps predict mortality of sepsis. The SOFA score, as many of you have heard, is way more expansive. There's a lot of components to it. I don't think it's less likely to test on all those individual components, but it's worth just glancing over. Septic shock is persistent hypotension requiring vasopressors and a serum lactate greater than 2 despite adequate volume resuscitation. All right, respiratory failure. So hypoxia causes, just so you guys understand, the most common causes are VQ mismatch, having some capillary membrane issues, airway obstruction, pulmonary compliance, and oxygen transport. And sometimes I like to have individual questions on different scenarios of these. So we'll go into some of the more high yield ones. Carboxyhemoglobin, as you know, that's carbon monoxide poisoning. So carbon monoxide binds to your heme with 240 greater affinity. So in order to diagnose this, you got to check the ABG with CO hemoglobin. The pulse ox will be falsely normal in this case and won't be able to tell between carbon monoxide or oxygen. So you'll be falsely reassured. And the treatment is with oxygen to displace the carbon monoxide. Met hemoglobin is oxidized iron in the heme, so it's in the wrong oxidation format. It's often acquired for medications or other reasons. You check an ABG as well. This one, the classic question stem is that the pulse ox is reading 85%, that it will be falsely reading 85%. Even if your real sat is 60%, it'll read 85 because of met hemoglobin. It confuses the sensor. So this one you treat with methylene blue. And lastly, cyanide poisoning. This question stem often is like industrial fires or solvent or plastic factory worker who got into a burn. You get anaerobic metabolism and see a high lactate. They will complain of headaches. Sometimes you can smell almond odor from them, although I've never smelled that myself. And the treatment here is cyanokit, as many of you already know. Ventilation modes. I think anyone who's been in the ICU kind of probably has a basic understanding of the vent modes, but I know a lot of the interns, this is relatively new in the second junior residence. So I'll quickly go over it. So, basically the idea is that you can control certain parameters in a vent and everything else will be as a result of those controls. So in volume control, the idea is that you deliver every breath at a same tidal volume, and it's either triggered by the vent at a minimum respiratory rate, and it's also supported whatever the patient triggers. So you can set the respiratory rate, the tidal volume, the PEEP, and the FiO2. And even if you set the respiratory rate at 12, the patient breathes at 18, you get 18 supported breaths. That's the idea. Pressure control is the opposite, where you set a set pressure for a set time, and depending on the airway resistance, X amount of volume gets delivered. So this could be dangerous in that if you say same pressure for everybody has different resistances, so you can end up with really high volumes or low volumes. So you got to watch what volumes are given. But it's better to control the pressure that's given so that you can control exactly what their pressure that's given by the vent. And here you'll control the respiratory rate, the inspiratory pressure, the inspiratory time, the PEEP, and the FiO2. And then SIMV, I think I see this a lot at Hartford Hospital, but it's basically a synchronous intermittent mandatory ventilation mode where you have a certain number of mandatory breaths with a fixed volume, but a patient can't trigger any extra breaths. So for a wide awake patient, this is actually pretty uncomfortable because they don't get any breaths that are supported, but the idea is that you make them work a little. So, and here it's pretty similar to the volume control, what you can set. And then lastly, pressure support is that all breaths are patient initiated. So basically it's like a pressure control with no mandatory breaths. So you just set the pressure support you're given, the PEEP and the FiO2, and then the patient determines the rate. If you're going to paralyze a patient, do not leave them in pressure support, because while all the vents I think have a backup mode if they become apneic, it generally, without the backup mode, you'll kill them. So that's one thing to keep in mind is that pressure support, the patient has to be able to breathe spontaneously. So you can't overly sedate them or paralyze them. All right, hope that helps a little bit. All right, so vent-related constants, quick hits. You're gonna be asked to analyze ABG. So in order to improve oxygenation, you have to control the FiO2 and PEEP. For ventilation, which is really CO2 removal, it's controlled by the minute ventilation, which you can either control the respiratory rate or the tidal volume. When they talk about peak pressures on the vent, that's actually the pressure seen in the airways. It's not, when I was young, I thought it was just like, oh, this is the pressure that the alveoli is feeling, but it's actually not true. The vent can only measure what the large airways are feeling. And only when you do an inspiratory pause, so at the end of inspiration, you let the pressure settle between the alveoli and the airways, that's called the plateau pressure. And that is actually indicative of your alveolar pressure down to the alveolus. So if you want to know what the actual alveolus are feeling, you got to get an inspiratory pause to measure plateau pressure. And then what is an expiratory pause? So that actually measures your auto PEEP. So it's the pressure above your PEEP level if any air is trapped in the lungs due to breath stacking. So the idea is that, if you set the ventilator to give 500 cc's of breath every breath, and you're only getting back 400, that 100 has to is staying in the lungs, right? So every breath, they get 100 extra that's not coming out. This happens a lot with COPD patients, people with having a hard time with long expiratory phases. So you can get breath stacking. You can actually start getting really hypotensive, and they can actually code on you. So in order to measure this correctly, you got to do expiratory pause to see at the end of expiration what the pressure in the airway is. And if it's way above your PEEP level, it means there's a lot of air trapping. And for treatment for this at the extreme is you just pop them off the vent, push their chest down, and put them back on the vent with either lower tidal volume or lower respiratory settings, or a longer expiratory phase, because they can't basically breathe out. They don't have enough time to breathe out the air you're giving them. So that's something that you'll encounter in your career eventually. You'll see someone with breath stacking. So it's something to keep out. And you got to measure an expiratory pause. And the RTs know how to do this if you're ever concerned. All right, this is always on the ABSITE, so I honestly always just looked it up right before. But the idea, something that's helpful to understand is that capacities are always an addition of volumes. So that this is the lung volume curve, during a breath. So as I'll quickly go over it. So as you all know, tidal volumes are just when you breathe normally up and down, that's how much volume it is. Inspiratory reserve volume is how much breath you can inhale above that. So that's IRV. And then vital capacity is how much can you exhale as much as you can from max to min. That's vital capacity, which is addition of IRV, tidal volume, and expiratory reserve volume. And the FRC is how much air is in at the end of expiration of normally, all the way to 0. And then residual volume is the air that you can't get out of your lungs because you can't completely collapse your lungs. So just go over this graph. Honestly, my advice to you is draw it out once and know that you can actually do it before the ABSITE, because it's something that I feel like if you don't do it, you'll definitely miss a point. So, and it's helpful to understand. All right. So as you may all heard, ventilator-induced lung injury, everything the vent does can cause injury. So increased tidal volume can cause volutrauma. Increased airway pressure can cause barotrauma. Oxygen toxicity from a high FiO2 over time will cause trauma as well. Atelectotrauma, something you may not have heard of, is when you set the PEEP close to where the alveolar is opening and closing, you'll get repetitive closing and opening of the alveoli. The idea is that it should just stay open. But if you keep closing the alveoli every single time, that can cause trauma as well. And lastly, biotrauma, by just the repetitive motion of providing positive pressure ventilation, you get inflammatory mediators released to the mechanical ventilation itself. So as many of you know, positive pressure ventilation is very opposite of how we breathe, right? We all breathe because the diaphragm and the intercostal muscles open, and the negative pressure allows air to enter into our lungs. But positive pressure ventilation is complete opposite, where you're just pushing air into the lungs. So it's very unnatural way of breathing. And the only thing that comes close to what we do as a normal without being on the ventilator is iron lung, as you may have heard of. So just keep that in mind, that when you're putting people on the ventilator, that it's completely opposite of what you and I do on a normal basis. So, all right, extubation criteria. This stuff always stressed me out as a resident because Sometimes as a senior resident, they'll ask you like, oh, is this patient ready for extubation? And you're like, I don't know. They eyeball fine, but what else am I supposed to do? So I thought I'd go over this, and they like to test it sometimes as well. So daily spontaneous awakening trials and spontaneous breathing trials are the standard of care in the ICU. The reason why is that they've actually done studies predicting how good providers are at predicting whether someone is extubatable. And we're like really bad, like almost coin flip bad. If you like leave it up to doctors and providers to predict who's going to get extubated or not, like it's so terribly bad that's why they made a rule that we should just do a standard spontaneous breathing trial to give everyone a chance every day. And you should know that we are terrible at this. Because we don't know until you try giving them a shot. So a spontaneous breathing trial is that you put them on pressure support mode, usually like 10/5 or low pressure mode setting for 30 minutes to up to 2 hours, no more than that. Don't make them spontaneous breathing trial all day if they can't tolerate it. And you monitor for increased work of breathing, basically anything that makes them look like they'll fail, higher respiratory rate, hypoxia, anything that you'll concern that they can't tolerate once they're extubated. Other useful adjunct measures are you can ask for RISB to the RT. And this is respiratory rate divided by total volume, or you can just calculate this, sorry. Respiratory rate divided by total volumes in liters. You want it less than 105. That's predictive for being able to be successful. You want to ask the RT to measure a NIF, so a negative inspiratory force. How much can they really pull on their own? And you want it to be at least -30 of negative inspiratory force. And then lastly, something that we're doing more recently is that you make sure there's a cuff leak to try to predict stridor risk of those who have lungs that are fine, but airway issues or airway edema. So you want to see if there's an audible cuff leak with the balloon down. Generally speaking, it's been taught that you want to aim for about a 10% reintubation rate. If it's 0% in your practice, it means you're not extubating enough. So it's okay to have reintubations, but around 10% is what you shoot for. If your reintubation rate is 100%, something's clearly wrong with you, sorry. So you got to shoot for somewhere for 10%. All right, moving on to ARDS. So quickly, I'll go over the Berlin criteria. So timing, respiratory symptoms has to be within 1 week of clinical insult. The imaging shows bilateral lung findings on chest X-ray or CT that are not explained by like effusion, lung collapse, or nodules. The edema can't be explained by fluid or cardiac overload or failure. And oxygenation, the P to F ratio, so PaO2 over FiO2 ratio has to be less than 300. And the grading is that 200 to 300 is mild, moderate is 100 to 200, and severe is less than 100. And the treatment of ARDS is really important and often on oral boards. So, and they'll really want you to be specific. So this is a question that I often ask during rounds in the ICU, and people always say like lung protective ventilation, or steroids and all these things. But then I quiz them like, what do you mean by that? What is exactly, because there's no RT or nurse to help you on oral boards. So you have to actually give me the exact prescription of what you're going to do. So just you got to be really specific in understanding this. So let's go into it. So lung protective ventilation, or you'll say low tidal volume ventilation, is that I will do 6 cc's per kg of ideal body weight. And this is not their normal weight, but ideal body weight determined by their height. You can always Google and pull up ARDS-net protocol and say, I said on my oral boards that I will do a lower PEEP ladder. So you can see there's a PEEP ladder on the bottom right here, where depending on the FiO2, you determine the PEEP. And the whole idea is that you go to pretty high PEEPs as your FiO2 goes up. The second thing you can do is Dexa ARD steroids. So dexamethasone, IV dexamethasone for 20 milligrams daily for 5 days, then 10 milligrams for 5 days for a total of 10-day course. And as the P to F gets severe, you can consider doing proning. These top 3 are the only ones really proven to show a mortality benefit, just FYI. The other stuff that we'll talk about, it has been mixed or not shown to help you have a mortality benefit, but it can definitely help oxygenate better, so we still do them. So those 3 are the mortality benefits. And with proning, you really need to have a good structure and infrastructure in your hospital in place to be able to do this safely, because you got to have a lot of people be able to flip them 16 hours a day, prevent pressure injuries, prevent extubations. And so you got to have some sort of practice in place and to be able to do this well. Neuromuscular blockade is we often do, as you'll know, when they get pretty severe. I generally think about it as a P to F ratio that gets less than 150. However, it's actually not really proven to help with mortality as much. So some people are against it because it is associated with a lot of morbidity, with muscle atrophy, debility, all that. So I would not do it for days and days and days. You got to give them a short-term course of that. Pulmonary vasodilators are, I think, often easily pulled, like Velitree, epoprostenol, or inhaled nitric oxide. Those definitely help with improving your PaO2 number, but have not shown to actually improve mortality, just FYI. But it does make us feel better because the PaO2 goes from like 50 to 80, and you're like, well, that's better. So, and then definitely keep in mind to shoot for negative fluid balance daily. You want to make sure you limit any chance of like fluid overload contributing to a hypoxia. So keep that in mind. And lastly, where I trained in fellowship was a huge VV ECMO center. So the teaching was that really no one should die of ARDS alone because there's VV ECMO as a last resort. So if you have a patient who's on near death's doors early on in their ARDS course, you should really call a VV ECMO center nearby you and have them transferred and cannulated and transferred. Because especially if they're young and they can, heal through this, they should not die of ARDS. So that's just sort of an opinion on my end, but I wouldn't necessarily say that on oral boards, but you can always mention that as a last resort. So, all right. Hope that was helpful.
Yes.
Okay. And this is really high yield. Like this is a lot of my friends, is like this is on a lot of the oral boards, written boards, ABSITE. It just keeps following you everywhere. And it's really important too. So because some of these things that we do have a mortality benefit. So the way I think about is that I actually say ARDS net protocol, because then you have the words. When I think of ARDS, I think of ARDS net protocol, DEXA ARDS. So the name allows you to remember what you're doing. So that's how I make sure I don't forget these things, and then think about the other things as well, like proning, neuromuscular blockade, vasodilators, etc. All right. Pulmonary embolism. I'm sure many of you have helped diagnose or treat these. So you all know the clinical signs of tachycardia, tachypnea, or hypoxia. I think the big important point is it's often you don't get all three. I've literally had patients who are about to go to LTAC and their heart rate is 105. They're not hypoxic, they're not tachypnic, but I'm like, let's be safe. They're a trauma patient, get a CTA, and bam, there's a PE, and you're like, come on, man. So you really got to have a high index of suspicion, especially in cancer and trauma patients. And anyone who's been admitted to the hospital for a while. Most common EKG finding is actually sinus tachycardia, even though we love to teach the S1, Q3 pattern that you hear about, but is not actually the most common. You all know you have to diagnose it with a CTA PE chest protocol. I'm sure it's been drilled into you that a D-dimer is pretty useless in our surgical population because in post-op patients, it tends to be elevated, and it's only helpful when it's low, not when it's high. You treat with heparin drip or therapeutic Lovenox for, pulmonary embolism that are not causing any hemodynamic issues or cardiac heart strain. But you always got to think about this is where a lot of people stop. They're like, they start the heparin drip and then walk away. But every time you diagnose a PE, always think about the possibility is that could this patient have obstructive shock or right heart strain, even if they're hemodynamically stable. So if they're hemodynamically unstable or significant right heart strain, like a massive PE that's shown in this photo, you need to call the PE response team if that's in your hospital to consider a catheter-directed or surgical thrombectomy. Or, if it's a code situation, we'll push, or near code situation, we'll push systemic TPA to try to save them. And even patients, I've had a patient once where we diagnosed a PE. It was like segmental. Patient was hemodynamically stable. We started heparin drip, then Lovenox, then Eliquis, and we're about to discharge them. And literally in front of the elevators, after being changed, he collapsed, even though he was stable throughout. And the teaching point, and this is when I was a resident, the teaching point is that we should have gotten an echo, right? If you have any concern about the size of the PE or the ability to tolerate it, you got to get an echo to rule out right heart strain. And he had a large right heart strain despite just having a segmental PE. So, and thankfully did okay after getting catheter-directed, treatment. But there was a big teaching point for me is that don't forget the echo and have a low threshold to order it. Next on acute liver failure. So something I learned in fellowship is that acute liver failure is really different than acute on chronic liver failure. So make sure you're looking at the question stem to see if they have any history of cirrhosis, because if they have a history of cirrhosis, it's acute on chronic liver failure, which is very different. And we'll just focus on acute liver failure here. So the idea is that you have a severe liver injury from a known insult or some sort of insult. the INR is greater than 1 or equal to 1.5, which is not a high number. And then you get hepatic encephalopathy with underlying cirrhosis. As a common question ABSITE likes to ask is, what is the most common, useful lab indicator for synthetic function of the liver? And it is the INR. So keep that in mind. The liver function tests are more like liver damage tests. So they're not actually that helpful, because if you have a cirrhotic liver, you actually may not have a big bump in your LLTs because it's kind of burned out already. So INR is actually the most helpful. And the causes of this, the most common cause we see is like Tylenol overdose, drug overdose, but you can see from viral hepatitis, autoimmune, hereditary conditions, toxins, ischemia, also from certain thyroid medications. I've seen it in as a consult resident as well. And something that's often tested on the, and you'll see and often tested, is that hepatorenal syndrome, where the kidneys shut down in the setting of acute liver injury and failure. So the idea here is that you get a portal hypertension, which then leads to splanchnic vasodilation of your mesentery, which then because of the vasodilation, your kidney thinks I gotta constrict to be able to perfuse better. So then you get renal it activates your renin-angiotensin system pathway, and then your kidneys get constricted abnormally, which then reduces your renal blood flow, and that decreases your GFR. So the idea is that the portal hypertension causes your body to activate your RAS system incorrectly, and then your body shuts down your kidneys basically on their own. And then now the new treatment that many of you may not have heard of is that terlipressin is a 2022 approved drug that's specifically indicated for hepatorenal syndrome. So that is your multiple choice answer, C, terlipressin, for this test question. And obviously you should, the one thing that you should do to test whether people do have hepatorenal syndrome is do an albumin challenge. So if they respond to the albumin challenge and it clears, it's not hepatorenal syndrome, because it just means they need to be fluid resuscitated. But if you give the albumin and the kidneys still don't get better in the setting of acute liver failure, then it's hepatorenal syndrome. So just keep that in mind. So depending on the questions, then the answer may be you got to give albumin to test it first, or if you've already diagnosed hepatorenal syndrome, then give terlipressin first line as well. And then obviously supportive care. There's nothing that actually cures people of this. Unfortunately, liver transplant will be the most effective or most definitive answer to fix this, if that's the questions then. So you got to read the questions carefully, because it'd be the next step versus most definitive are different answer choices, as you all know. Abdominal compartment syndrome, the bane of our general surgery residency. So intra-abdominal hypertension is sustained intra-abdominal pressure greater than 12 millimeters of mercury. As many of you know, when you do the Veris entry, you get a quick idea of what people's intra-abdominal pressure is. Normal is around 0 to 5, right? Sometimes in obese people it can be like 7 or 8 or a little higher. Abdominal compartment syndrome, the definition is that you get an intra-abdominal pressure greater than 20 with new and progressive organ dysfunction. So the really important part is that you get the organ dysfunction, not just a high pressure, because I would say half of my abdominal compartment syndrome consults are like, oh, you have a patient in the ICU in the MICU. We measure bladder pressure without paralysis, and it's 23. The patient has compartment syndrome. They need an XLAP. Please come now. And you're like, hold your horses. Let's really see if this is real or not. So, and you really have to get a bladder pressure with paralysis on board to really get an accurate bladder pressure. And a bladder pressure is still an indirect measure of the intra-abdominal pressure. Keep that in mind. So it's not one-to-one necessarily. And then you gotta see if they have all the other symptoms. So are they getting oliguric? Do they have an AKI? Do they have elevated peak pressures on the vent? Because you're fighting against a huge pressure of the belly. So if your peak pressures are like low 20s, the patient does not have compartment syndrome, right? Because like the vent will be fighting a much higher pressure to be able to ventilate. So that alone kind of rules it out. If they have rising lactate, acidosis, all these things, just like compartment syndrome of the leg, it's really a clinical diagnosis as well. So don't just hang your hat on any one number. Usually it's iatrogenic. We often see it from pancreatitis. You can actually see it from a very large retroperitoneal hematoma. So as we do more and more endovascular procedures, you'll see consults for like very large retroperitoneal hematoma. So while it's very easy to sign off when their H&H is stable, always keep in mind that there's a chance that they can get compartment syndrome. So keep that in mind when you're seeing those consults, if it's from large ascites. And then lastly, I've had to XLAP people in the ICU with massive hemorrhage after surgery that cause compartment syndrome. And those are pretty clear cut. Like they got a brick wall, their drains are pouring out, and you got to just go back in. And they have compartment syndrome because they're stopped making urine altogether. So treatment really is an emergent decompressive laparotomy, and probably the most common reason to do a laparotomy in the ICU if that's your hospital's practice. And in rare cases, if it's just from significant ascites, you can try a paracentesis first before you do a major XLAP, because while this is life-saving, it's hugely morbid as well, right? You gotta counsel, really have a goals of care discussion with the family that they may die with a big open belly, and that's if that's what they want. So I always make it really clear how morbid this will be, even if we get the patient through this. But if they do well, then they hopefully will get through it. But oftentimes there's many reasons why they're getting compartment syndrome, and they're pretty sick. So you gotta really get across the serious nature of what we're doing. So, all right. Hope you guys are still with me. We're almost near the end. And then one of the things that often they like to test, and I think causes a lot of anxiety. I don't think I had to really do this as a resident, but I had to do this as a fellow in the ICU. And they like to test this on the ABSITE is brain death testing. So I just want to go over the main components of it. If you ever do brain death testing as a provider, really every hospital has a customized protocol. So I recommend you print it out and follow it as a checklist, like bullet by bullet, because you really don't want to miss things. Like just like when you're setting up a bedside procedure, like if you're missing that one adapter, like the whole procedure is kaput, right? So I think a brain death testing is the same way. You cannot miss a single thing. So I just print the protocol out. I don't do it from memory, and I go step by step to make sure I don't miss anything. So main points that you want to make sure the patient has as homeostasis as possible. So normal thermic, normal acid base, MAP greater than 60 with some pressors if needed. Rule out confounders like drugs, neuromuscular blockade. A lot of hospitals, my fellowship practice was to actually get a formal pharmacy consult so they can actually look at the half-lives of everything that was given, like the fentanyl, the Versed, everything that was given to make sure that was all cleared by the time of exam. You got to do a clinical exam to test for all the brainstem reflexes, and these are the reflexes that like you don't know since you've learned them in med school. So it's helpful to, if you've never seen one, to like shadow and see another person do them so that you kind of know how to do them. So the cold calorics, the doll's eyes, all the different, the gag, the corneals, the cough, all of those, you got to do them. And unfortunately, in trauma patients with C collars, you can't really do the doll's eyes and shake their head around. So you often end up having to need to do an ancillary test, like a cerebral blood flow study, whether it's like a nuclear study or a CTA, and then or a transcranial Doppler. And then there's always some sort of special clause state dependent for kids. Like where I did fellowship, there were a lot of, you had to actually have a neuro quick care certified provider do one exam and a separate exam. So 2 separate exams for kids. So keep that in mind as well. All right, and then this is the last slide. So this is some of the stuff relevant to quick care and some of it not relevant to quick care that I kind of, if you want to take a picture of it, honestly, things to cram right before the ABSITE, because honestly, when's the last time you did a nitrogen balance on someone? But they love to test it for whatever reason. So I'll just quickly go over it so you rehashes your memory in case it shows up. Oxygen delivery is cardiac output times arterial oxygen content. And arterial oxygen content is really determined by your hemoglobin and your SAT, and your PaO2 has a really negligible contribution to this. They like testing that. Your respiratory, so you got to raise your hemoglobin often or your SAT first. Your respiratory quotient is your CO2 produced and O2 consumed. So if your RQ is greater than 1, you're overfeeding the patient. If it's less than 0.7, you're starving the patient. Nitrogen balance, I feel like I got grilled on nitrogen balance so often for when I've never used it. But protein intake divided by 6.25 minus urinary loss of urine nitrogen plus 4. And normal intake, it's helpful to know the normal intakes on the burn and trauma patients are higher, but normal is 25 kcals per kg per day. Goal protein intake is 1 to 1.5 grams per kg per day. Honestly, just memorize all the vitamin mineral deficiencies the day before the test, because I can never remember the copper, selenium, all those different little ones. And you may know it all, but I just had to cram right before. Acid-base disorders, those are really helpful because there's always a question, because they know that you've forgotten all the formulas by the time of the exam. So go over your anion gap calculation, how to do a compensation for the simple acid-base compensations, and then the delta calculations. This is where most people get lost, is the third part. So make sure you know how to do the delta calculations for mixed acid-base, because it's such an easy question to get if you understand it, but if you'll miss it if you don't know how to do it. So. And then lung volumes and capacities, like I showed you earlier, make sure you know how to draw that out yourself, measure all the different volumes and capacitance, know that you can do it. GCS is always on there. So I4, verbal 5, motor 6. Make sure you can actually recite every single one and what they mean, whether the corticate or the cerebral posture and what score that is. Because if you're even slightly unsure, they'll make sure you miss that question. So, and then lastly, the statistics 2x2 table for sensitivity and specificity is always on there, at least when I took it. So I'll make sure you understand the true positive, false positive, all those ways to calculate those things. So hope that was somewhat helpful. That's it. That's all I got.
Thank you.
End early so I can give you some time back to your lives. So
that's a question, Dr. Kim.
sure.
So in a patient with obvious abdominal compartment syndrome with multiple organ dysfunction, the best next step is to measure the abdominal compartment or to go ahead with laparotomy if it's clinically evident.
Yeah, I mean, a lot of times you will get a pressure just to confirm, but if it's clinically evident, like if they have a brick wall and they're not making urine and their lactate's rising and their peak pressure is in the high 30s, you're not wrong just to go ahead and do the laparotomy. But it's really not that hard to get a quick bladder pressure, if you're able to. If they don't have a bladder, I guess that's a problem. But otherwise, I would think almost always the ICU has already done a bladder pressure when they're calling you, just like you almost always have a CT before a consult these days. But yes, I think clinical diagnosis always trumps getting more numbers. So if you are pretty confident and your team is confident that it's compartment syndrome, then you got to do the laparotomies. And unfortunately, I've had to do a number of these throughout my career, and you know, it's not subtle. It's like you get a big burst as you open the belly. So, and you know, if you always admire the PDS stitches that the previous person did so well as you're cutting them. So if it's post-op patient. Yeah. Any other questions?
I think the next question is, can you review the common ethical quandaries or complications regarding brain death testing?
Say that one more time.
Can you review common ethical quandaries / complications regarding brain death testing?
Yeah, I think some of the common ethical parts that come up, and I don't know how much of this is on the test, but like for instance, like families sometimes in real life request that you delay brain death testing or don't do it. And unfortunately, as you know, federal law is that brain death is still death, same as cardiac death. So the way I was taught is that not checking for a brain death testing is like not checking a pulse on a patient. And you and I would never not check a pulse on a patient, right? Even if the family asked. So while you can sometimes time it so that the family is there when you're doing the brain death testing or all that, like within 24 hours, you really should not delay it. So that's often a common moral like thing that comes up. And once it's diagnosed, you know, the patient is fully brain dead, you know, you declare time of death. And another thing that comes up on the ABSITE is you as a provider or treating provider should never bring up organ donation with the family or patient. That is a big no-no, morally speaking. And I've like avoided it at all costs. However, the UNOS or the organ donation team can go up and talk to the family, and that's their job. But it's a complete conflict of interest to actually bring up anything related to organ donation as the diagnosing ICU physician. So hope that helps a little bit. And you know, if there's any uncertainty with clinical exam or apnea test from your exam, obviously an ancillary test that's when they often kick in. And with the ancillary test, what you're trying to get at is seeing if there's any sign of blood flow to the brain. So if there's any sign of blood flow, it doesn't, basically you can't diagnose brain death. But if there's zero blood flow to the brain, you're pretty confident that that brain is definitely gone and dead. So. Were there other questions?
All right, awesome. Thank you.